Thyroid research is really important because thyroid conditions are so common in the population. Whether it's younger people, middle-aged people, older people, thyroid disease is prevalent and fairly common. In younger people, abnormal thyroid function tests are seen frequently. In middle-aged people, particularly pregnancy, conception age women, it's an issue. Older people, it's even more so. And it's really surprising that the amount of research that's done in thyroid disease is so little and so few projects are being done. So given the prevalence, it's really important that we try and understand more about what is causing this and how best to treat it. Thyroid function tests are one of the most frequently asked for tests by clinicians. We test every person once every couple of years. And the more we test, the more abnormalities we tend to find. So I think it's a combination of more frequent testing and better awareness, either because of clinical awareness or possibly even the patients being more aware due to information from various sources, including social media. Hyperthyroidism or overactive thyroid, half of 1% are likely to develop that in the general population. Hypothyroidism is generally about 5% of the population, more common in older people, so some data suggests up to 10%, younger people slightly less. Again, the assumption from various statistical analyses shows that up to 500,000 people in the UK are being prescribed levothyroxine, which is a thyroid hormone supplement. Probably even more in other parts of the world. In the USA, levothyroxine was the most commonly prescribed drug a couple of years ago. In the UK, it was the third most commonly prescribed drug. There are a number of areas that have shown a lot of promise. Graves' disease is one such condition. It's an autoimmune condition where the immune system attacks and stimulates the thyroid and makes it produce excessive amount of thyroid hormones. And historically, the treatment had been to suppress thyroid hormone production and waiting for time to deal with the immune system to settle down. If not with medications, then surgery or blasting the thyroid with radioactive iodine were the treatments. But more recently, people have started to focus on the immune system itself and how modulating the immune system might help in lowering the risk of Graves' disease or improving its outcomes. So that's a really exciting area currently. Thyroid eye disease is the other one, and that has seen tremendous improvement. There are lots and lots of medications already there and more in the pipeline that are dealing with thyroid eye disease, which is a really, in people who get affected, a quite disabling condition in so many ways. Thyroid cancer has seen lots of developments over the last decade or two. Thyroid nodules, which are benign growths, but that can cause physical compressive effects, those are seeing some new developments in how you best manage them, because either it was leaving them alone in the past or it was surgery, but now there are radiofrequency ablation methods where you insert a probe and using radiofrequency waves, the damage to the thyroid nodule is created, so it shrinks. Laser treatment and so on. So there are all these improvements and exciting opportunities that are being created. Hypothyroidism hasn't really seen as much of an advance, but the areas that are seeing some areas that are being looked at include refining how best we treat and who we treat. As an example, 15-20 years ago, it was thought that older people are more likely to develop hypothyroidism, particularly the milder version of it, called subclinical hypothyroidism. However, in the last 15-20 years, it's being recognized that it's not really a mild hypothyroidism, it's probably a variation of normal. It might be actually normal for older people to have a slightly lower thyroid function. And therefore, there have been trials that have shown that treatment has really no benefit. So we have learned who we should be treating and who we should probably not be treating in terms of hypothyroidism. The other area that is being assessed is whether thyroxine or T4 on its own is the only thyroid hormone that should be replaced, or whether there is a role of T3. The jury is still out. The overwhelming evidence so far suggests that T4 should remain the mainstay, but there are trials going on in the UK and elsewhere that are assessing whether targeted T4 and T3 combination might be appropriate for some patients. So there are lots of areas that are being looked at. It's an exciting time to be involved in thyroid research. Time will tell how things progress. There's lots of other actually interesting areas as well, apart from the ones that I've mentioned. The genetics of thyroid disease, what influences thyroid function, what effect does external factors have on genes that influence thyroid hormone function. Other thyroid hormone, what are called metabolites or breakdown products, can we measure them? Do they have any role in the functioning of the body? So over the last 10-15 years, we have started finding ways of actually measuring these metabolites in the blood. And the next step would be then see whether they have a functional role and then taking it forward from there. So great times. Over the last so many years, I've been quite lucky to be involved in lots of aspects of thyroid research. To keep things simple, I can focus on three main parts of it. One, with the support of the British Thyroid Foundation, was examining the changes in thyroid function over time in the same group of individuals. There was a landmark study performed in the 1970s called the Wickham survey. And for people who may not be aware, Wickham is an area that's quite close to Newcastle and Gateshead in the northeast of England. So in the 1970s, a gentleman called Mike Tunbridge performed the first survey of its kind in the world, where he assessed the prevalence of thyroid disease in the general population. 20 years later, his student, Mark Vanderpump, performed a 20-year follow-up of the same cohort to try and find out who had survived and who hadn't, who had developed thyroid conditions, and was able to look at the data from 20 years before and 20 years later. And another 15-16 years after the second survey, I was lucky enough to be able to then look at the survivors and also look at changes in thyroid function over a period of time. And that has been really rewarding, trying to assess the same group of people over such a long period of time. So that has been really useful. And it has shown to some extent that thyroid function does change with time. In the same individual, as one gets older, the thyroid does change. The second trial that I've been involved with is assessing thyroid function replacement in older people. So it was a feasibility trial of assessing the right dose of thyroxine to be given people who were aged 80 or more. The theory I had is that we shouldn't be giving the same dose to older people as you'd give to somebody who was a lot younger. So we gave older people a lower dose compared to younger people to assess how they felt in a blinded fashion. So they weren't aware whether they were getting the same dose as before or a lower dose. And we found that it actually didn't make them feel any different. So there is a potential that we might be able to give a slightly lower dose, but this will need to be proven in much larger trials. So that was really interesting and thought-provoking, and that now needs to be taken on to the next step. Third project I was involved with was called Thyroid, where we recruited patients who had just had a heart attack and who had evidence of a mild underactive thyroid, and we treated half of these patients with thyroxine and the other half with a dummy tablet called placebo, and the aim was to see whether treatment of their underactive thyroid would improve their heart muscle function. And it didn't really show any benefit, and it was important in all sorts of ways. It first of all showed us that underactive thyroid in that particular situation is relatively common. 10 to 15% of patients had that evidence on the blood test. And the next and probably more important aspect of this was that treatment didn't really show any benefit, which suggests that checking the blood test is okay, but we probably shouldn't be treating these people. Thyroid disease is very common, but the funding that's available is very, very limited. There are no, massive charities out there that fund research. One of the main charities around is the British Thyroid Foundation, and the BTF have played a huge role in improving the lives of many, many patients with thyroid conditions. One of the areas they really help is by providing an annual research award. And a few years ago, I was lucky enough to be one of these award winners. The amount is modest, but what it does do is provide you with the opportunity to perform a study to be able to collect the information that would then become important for a subsequent, much larger study to be done. A lot of funders, particularly if, for example, if they're government funding bodies like the NIHR or MRC, would like to see some proof of the concept that you have. And the funding from the BTF allows that to happen by providing that grant. So I would say the award from the BTF was crucial in so many ways in being able to progress from just a thought to actually doing the research.